invite Dr. Clare Fraser to be, she'll be talking to us about sleep apnea in neuro ophthalmology.
Thank you very much for the invitation to be part of this conclave. I hope you can all see my slides okay. So obstructive sleep apnea is the repetitive, partial or complete collapse of the pharynx with resultant hypoxia at nighttime. In India, based on some data from ResMed, it's about a 13.7% prevalence, higher in men than women, and significantly higher in men over 60 living in metropolitan areas, and much lower in rural India, though whether this is because of poor diagnosis, I'm not too sure. The gold standard diagnosis is an overnight polysomnography, where they measure apneas, which are a reduction of airflow to less than 10%, and a hypopnea, which is a reduction of airflow to less than 50% with a 4% oxygen desaturation. So we can classify sleep apnea as mild, moderate, or severe, depending on this AHI. It's very important to diagnose obstructive sleep apnea because it does result in increased morbidity from diabetes, cardiovascular disease, hypertension, as well as an overall increase in mortality. And it reduces all quality of life measures and is independent. The risk of this is independent of the comorbid obesity. It's associated with a range of ophthalmic conditions, including keratoconus and floppy eyelid syndrome, worsening of diabetic retinopathy, central serous retinopathy, glaucoma, NAION, and as I'll show you now, also thought to be related to idiopathic intracranial hypertension. So what is the evidence for a link between obstructive sleep apnea and non-arteritic anterior ischemic optic neuropathy? Well, firstly, there is a plausible pathophysiological process. The sympathetic overactivity and surges in blood flow velocity caused by the sleep apnea impaired the plial vessel autoregulation. The associated hypertension, atherosclerosis, and arterial stiffness alter the blood flow, and the direct hypoxia, as well as all of these, lead directly to optic nerve head ischemia. In past papers, they've shown that patients with NAION have a significantly higher rates of obstructive sleep apnea compared to control populations in the same group. And we also know from this large Korean-based study that the hazard ratio of NAION is significantly higher in patients with known obstructive sleep apnea. It's also been shown in particular to be related to patients who get NAION under the age of 50. So certainly if you have an NAION patient under 50, we'd be strongly recommending screening for obstructive sleep apnea. So the question then is, does treatment for sleep apnea mitigate this risk for NAION? And definitely the studies are showing that it does. We know that if you have untreated obstructive sleep apnea, there is a 16% increased hazard of developing NAION, and this is based on a US population database. And in this study, they found that obstructive sleep apnea was associated with an increased rate of NAION occurring in the fellow eye. And what was particularly interesting is if the patients were CPAP non-compliant, that was particularly related to fellow eye involvement in NAION. So I think we've got good evidence that obstructive sleep apnea is associated. So what about this link with idiopathic intracranial hypertension? Again, we know that the swings and elevations of intrathoracic pressure increase the venous pressure. The hypoxia and hypercapnia, of the sleep apnea, as well as the sympathetic overactivity, result in cerebral vasodilation, increasing intracranial pressure, and the direct hypoxia coupled with all of this result in worse papilledema. We know that from some background research that optic disc swelling is seen at high altitude related to peripheral oxygen saturation. And interestingly, we also know that patients on CPAP treating their sleep apnea show a 4% decrease in total brain volume. So there's certainly some plausible pathophysiological links here. Looking at patients with papilledema, we know that if you do overnight pressure monitoring, that they get nocturnal spikes in their intracranial pressure related with these episodes of apnea and arterial oxygen desaturation. So the episodic hypoxia and hypercarbia is resulting in this cerebral vasodilation and the raised intracranial pressure, and the hypoxia puts those patients at greater risk of vision loss. Looking at sleep apnea, particularly in men, we've got several cases showing that treating the sleep apnea alone is enough to resolve the intracranial hypertension. And in a comparison of men with IAH compared to controls, the IAH patients were much more likely to have a positive Berlin questionnaire, which is one of the screening tools for obstructive sleep apnea. This is a new study which is on an all-female cohort where they looked at patients who are under either bariatric surgery or community weight loss with their IAH. And of those patients that had obstructive sleep apnea, the stop-bang questionnaire was the highest sensitivity. And I'll go through that and show you how you can use that in your patients. We know that the obstructive sleep apnea patients did significantly worse with their IAH, even though they had no difference in their baseline characteristics. The sleep apnea patients had much poorer outcomes at 12 months with relation to the lumbar puncture opening pressure, the optic nerve head volume, and the mean visual field deviation. And what was interesting, if you improved the obstructive sleep apnea measurements, they had improved papilledema, independent of their weight loss, and improving AHI correlated with falling raised intracranial pressure. So treating the sleep apnea resulted in improvements. So when should we definitely look for sleep apnea? I certainly think men with IAH. If there's vision loss or papilledema that's out of keeping with the other clinical findings, obviously, if they have concurrent clinical signs such as floppy eyelid syndrome, which is leaning you to thinking that they have sleep apnea, and really an argument could be made to screen every IAH patient for obstructive sleep apnea, given that we know that they have worse visual outcomes down the track. So what are you going to do in your clinical practice? And I would strongly recommend that you apply the stop-bang questionnaire to your patients. It's a very quick and easy thing to do. We ask about snoring, daytime tiredness, observed apneas with their partner, high blood pressure, a body mass index of over 35, an age of over 50, a neck circumference of over 40, and a male gender. And you can then score this, and then depending on whether the patient is low, intermediate, or high risk, they then go on to be considered high or low risk for obstructive sleep apnea, and you can then refer them on to formal diagnostic testing and treatment. So really, in conclusion, should you ask about obstructive sleep apnea and perform a sleep study in those patients with NAION? Absolutely. I think there's no question about that with NAION. IAH, I think it's really useful to do the stop-bang questionnaire and send those patients on with who are high risk for further study. Thank you very much.
Thank you, Dr. Clare, for a brief review.